kind of introduction. I will talk about IFA ablation or TAE, which procedure is better for huge thyroid nodule goiter. Let's definition the thyroid volume. The average volume of thyroid gland is approximately 6.6 milliliter. Thyroid nodule volumes are defined as a small nodule have a volume of less than 10 milliliter. Medium nodules range from 10 to 30 milliliter, and large thyroid nodules exceed 30 millimeter. Huge thyroid nodules are defined as those with a volume greater than 100 milliliter. So huge thyroid nodules are often associated with intrathyroid goiter, and the traditional treatment for intrathyroid goiter is surgery, which sometimes requires an extracervical approach. However, patients who underwent an extracervical approach tend to have a higher complication rate and longer post-operative hospital stay. We can see the CT image, the intrathyroid goiter shows thyroid goiter through the thoracic cavity and the upper mediastinum and the compression trachea and the gray vessels. It's difficult for the treatment. Okay. So as we know, thyroid goiter is a prevalent condition, and the treatment mainly in dealing with compressive symptoms and the cosmetic concerns. The traditional treatment is surgery. However, there is concern of the cervical scar, requirement for a hormone replacement, and the possibility of injury to the recurrent laryngeal nerve. In response to the risk, there has been a shift toward to a minimal invasive technique, especially radiofrequency ablation. However, there is a challenge when facing a huge thyroid nodule goiter, and this is where the transarterial embolization has emerged as a potential option. To achieve a satisfactory clinical result, thyroid goiter over 100 milliliters often require multi-section of RFA. To see the intrathoracic goiter, the ultrasound transducer was placed cranially to the clavicle with the caudal tilting angle. However, the lower portion of the thyroid goiter is often difficult to identify. We can see the picture when we do the ultrasound guided IFA. The intrathoracic goiter is obliteration by sternum and the clavicle. So our probe is placed cranially to the clavicle and with a caudal tilting angle. But then IFA needle is here, and we often difficult to see the inferior portion of the thyroid nodule goiter. So huge thyroid nodule may present difficulty in achieving uniform heat distribution and may also be compromised in highly vascular nodules due to heat dissipation. As larger nodules tend to have more abundant vascularity. Additionally, when a nodule extends into the thoracic cavity, anatomical constraints at the thoracic inlay referred to the bottleneck hypothesis suggests the physical limitation can restrain optimal volume reduction. Okay. Technique factors including the need for precise nodule visualization and approximately ablation technique selection may also impact the overall procedure effectiveness. Furthermore, patient-specific factors such as the proximity of critical structure to the thyroid gland require a more cautiousness approach to avoid complications, potentially leading to a reduced volume reduction ratio. Moreover, incomplete ablation may facilitate potential regrowth, resulting in suboptimal outcomes. So how about thyroid TAE transarterial embolization? Several previous study about TAE, the main indication was for toxic diffuse goiter and can improve the thyroid function. But interesting, in that time, the secondary effect in decreased thyroid volume did not receive enough attention decades ago. The target of transarterial embolization for thyroid nodule goiter is bilateral superior thyroid artery because they supply more than 70% of blood supply of the thyroid nodule goiter. Okay. So factors that may cause great volume reduction in thyroid artery embolization. TAE offers distinct advantages in treatment nodules with a rich blood supply by using embolic materials to effectively reduce blood flow to the nodule, thereby promoting its shrinkage. However, I feel which ablation tissue through heat can be limited by heat dissipation by blood flow, potentially affected the final therapeutic outcome. The effect of IFA is further influenced by presence of calcification within the nodule. Previous studies have shown that calcification may present in 8% to 32% of nodules tend to increase with patient's age and the duration of nodules. Calcification can hinder the movement of the electrode tips and impair the heat conduction to the target tissue by altering electrode and thermal conductions, potentially leading to suboptimal ablation result. In contrast, the effectiveness of TA is less affected by calcification and by other factors previously mentioned, such as intrathoracic extension, and the need to more cautiousness preserve adjacent vital structures. A recent study on the treatment of a huge thyroid nodular goiter using IFA or TAE was published in European Radiology this year. This multi-center study included 90 patients who underwent TAE and 57 patients who received IFA. Subgroup analysis was performed according to nodule volume and the diameter to compare volume reduction rate, procedure time, thoracic extension, complications, and symptom and cosmetic score. So we divide enrolled patients into 3 groups by prevalent, which are less than 50, and 50 to 100, and larger than 100 milliliters. In patients treated with IFA allow no significance, the larger nodules tend to have a lower volume reduction ratio. In contrast, patients treated with TAE did not show such kind of trait. Furthermore, the subgroup with pre-ablation volume over 100 milliliter, the TAE group show a significant higher volume reduction rate, and the actual volume reduction compared with IFA groups. So we also divide the patient by the maximum diameter of thyroid huge nodular goiter. A similar trail was also seen in where large nodules exhibit a reduced volume reduction rate in the IFA group. Notable in subgroups with maximum diameter exceed 9 centimeter, the TAE groups exhibit a significant higher volume reduction ratio compared to IFA group. So we can see our patients, the IFA group and the TAE groups. We could see that even though the nodule is huge, TAE may still reach a significant volume reduction. The inferior portion of intrathoracic goiter show up elevated. So we can see the huge thyroid nodular goiter with intrathoracic extension, but TAE group with a better volume reduction ratio. Also, how about the complications? no thyroid stone noted in all TAE patients, and no major complication in 2 groups. Total 8 cases of minor complication noted in IFA groups and 1 in TAE groups. So higher minor complication rate in IFA groups when nodular volume greater than 100 milliliter. So although both IFA and the TAE treatment in large thyroid goiter shows both adequate efficacy and safety profile, when goiter exceeded 100 milliliters or diameter exceeds 9 centimeters, TAE might be a more effectiveness and more safety approach rather than IFA. But TAE is not only primary treatment, but also it can be a bridge treatment for a huge thyroid goiter. If patient with a huge thyroid nodular goiter but refuse to operation or not a good candidate for surgery, TAE could be a primary treatment to with a good volume reduction ratio and improved intrathoracic extension. After follow-up, if improve the intrathoracic extension of huge thyroid goiter, we can shift to IFA treatment for better peripheral control and better growth control. So combination of 2 treatment may be more effective in treatment huge thyroid nodular goiters. Thank you for your patience.